Good morning to all of you. At the outset, I would like to thank the IN for providing me this opportunity to take this class on the clinical localization and approach to radiculopathies and plexopathies. Radiculopathies are often encountered in both the outpatient and inpatient setting, in both the general hospital as well as the neurology specialist setup. Plexopathies, on the other hand, are not as common. But since the symptoms and signs are rather similar, it is sometimes difficult to distinguish radiculopathies from plexopathies and also from the more commonly occurring neuropathies. And plexopathies in particular are considered to be rather difficult disorders. It is important to clinically localize the lesion as accurately as possible because while the number of differential diagnoses for which a patient needs to
Dr. Madhu, can be a little loud, closer to the mic.
To treatment and prognosis are rather diverse. Clinical localization is also important in order to carry out the next important step of deciding the investigations judiciously and also for interpreting the results accurately. For example, consider this case scenario wherein an elderly gentleman presents with numbness of the fourth and fifth digits of the left hand following a CABG procedure. Examination shows reduced sensation of the fourth and fifth digits, the medial one-third of the palm, as well as the medial side of the forearm, along with weakness of the intrinsic hand muscles and the wrist flexors. Now, based on these clinical features, the possible localization could be the ulnar nerve, the medial cord, or the lower trunk. So how do we sort out this problem? This problem-solving exercise could be extremely perplexing and irritating unless we are equipped with a sound knowledge of the anatomy, in which case it could become extremely rewarding and pleasurable. Let us revise some basic facts. Here is a schematic representation of the peripheral nervous system. As you all know, there are 31 pairs of spinal nerves that innervate the limbs and the trunk. Each spinal root is made up of the dorsal or the sensory root with the dorsal root ganglion, as well as a ventral or a motor root. These roots fuse in the intervertebral foramen, just distal to the dorsal root ganglion to form the spinal nerve. The spinal nerve gives off a small posterior primary ramus and then continues as the anterior primary ramus that innervates the limbs and the trunk, as well as participates in the formation of the plexuses and the peripheral nerves. Just outside the intervertebral foramina, the anterior or the ventral primary rami also receive a gray rami communicants from the sympathetic trunk. Now, although anatomists describe the anterior primary rami as the roots of the plexuses, much of the surgical literature, particularly with respect to the brachial plexus, defines the roots as those peripheral nervous system elements that are proximal to the trunks. We shall once again consider these elements later. The plexuses are complex structures that supply the upper and the lower limbs. They connect the central nervous system with the sensory and the motor end organs. They are formed by a network of fusion and division of nerve fibers that originate from the cervical and the upper thoracic regions, as well as the lumbosacral nerve roots. They terminate as named nerves that innervate the muscles and the skin of the upper limbs and the lower limbs. Today, we are going to cover the topic under the following headings. First, we shall tackle the radiculopathies. Coming to the disorders of the roots or radicals, or what are called as radiculopathies, the identification of lesions that affect single radicals requires a precise knowledge of the cutaneous regions that are supplied by a single spinal nerve root, as well as the group of muscles that are innervated by a single spinal root. These, as you all know, are referred to as the dermatomes and the myotomes respectively. In addition, in certain older literature, you could come across the angiotome as well as the entratome as well. This knowledge is necessary in order to identify the segmental nature of the sensory and motor symptoms and signs. The dermatomal segments are arranged in an orderly manner in the cradiocaudal direction from the cervical to the sacral region. Developmentally, the C5 to T1 segments supply the upper limbs, while the L3 to S2 segments supply the lower limbs, and therefore they are not represented in the trunk. Thus, the C4 impinges on the T2, while the L3 impinges on the S2. These lines of cleavage represent the gaps in the numerical ordering of these dermatomal sequences, and they are referred to as the axial lines. In addition, there are also individual variations in the dermatomal distributions, and these have to be kept in mind while evaluating any patient. The innervation of most of the skeletal muscles is polyradicular. However, some of the muscles are situated in the center of a myotome. They are almost completely dependent upon a single nerve root, and therefore they are of diagnostic importance in identifying lesions of single roots. And for this reason, they are referred to as the segment pointer muscles. One must remember at this point that there are topographical discrepancies between the dermatomes and the myotomes. That is, they are generally widely separated from one another. For instance, take the example of the intercostal muscles that receive a monoradicular supply from the corresponding spinal segments. Now, the dermatomes that corresponding to these spinal segments lie distal to these myotomes, and this gap increases as we proceed caudally. So, the T11 myotome lies under the T9 dermatome. Likewise, the muscles of the shoulder girdle, such as the spina tii and the rhomboids that are supplied by the cervical segments and therefore represent the cervical myotomes, extend far below the thoracic dermatomes. Similarly, the distribution of the autonomic outflow also differs from the dermatomal distribution of the somatic outflow because the spinal segments that give rise to these autonomic efferents are rather restricted. Coming to some of the common etiologies that affect the roots, some of them affect single roots or a group of roots, while there are other diseases that affect the roots diffusely. And therefore, we have the monoradiculopathies and the polyradiculopathies. Polyradiculopathies give rise to diffuse weakness, hyporeflexia or areflexia, and they have an acute, subacute or a chronic course depending upon the interval between the onset of neurological illness to the attainment of peak neurological deficits. Most of them are immune mediated and they share several common features with the polyneuropathies that I think has been covered in the previous session. So, the clinical symptoms and signs are not different from that of other peripheral nervous system disorders, and they include positive and negative sensory and motor symptoms and signs. But a defect in a single spinal root is compensated in majority of the muscles by impulses that are transmitted through the adjacent roots. This explains why paresis is often compensated and atrophy is often masked or appears insignificant because of compensatory hypertrophy of the residual muscle. So, we make use of the segment pointer muscles, which even in lesions of single spinal nerves regularly suffer from marked functional loss and may even have atrophy with or without fasciculations. So, the characteristic segment pointer muscle is the extensor hallucis longus for the L5 root, as you all know, and these are the other roots and the corresponding muscles that are weak during dysfunction of the individual roots. However, the muscle stretch reflexes are sensitive to disturbance of single roots because their reflex arc is disturbed. Thus, loss or diminution of a reflex may be the only objective sign of a lesion in the root. Symptomatically, patients often report a radicular pain or a root pain. Pain is often the first manifestation of a sensory radiculopathy. It often has a characteristic lancinating or an electrical or a burning quality. This pain is abrupt, sharp, well localized, and it is referred to a specific dermatome or a myotome, and it is characteristically accentuated by increase in intraspinal pressure, such as by coughing or straining, or by stretching of the dorsal nerve root. It may also be accompanied by paresthesias or dysesthesias in the area that is affected. Patients also report hyposthesia or anesthesia that is confined to the specific dermatome that is involved, but again, because of the significant overlap, the lesions of single nerve roots do not cause significant sensory loss. Therefore, the absence of sensory loss does not exclude the possibility of a lesion affecting a single spinal root. When multiple spinal roots are affected, then sensory loss may be more evident, but here also the area of analgesia is larger than the area of anesthesia to light touch, meaning the area of analgesia, that is to pain, is much larger than the area of reduction in touch sensation. There are a number of bedside maneuvers that can provoke or reduce the radicular pain. Some of them are the Sperling test, the straight leg raising test, etc., and they can be used to identify radiculopathies. One interesting phenomenon that occurs in the setting of diabetes is the occurrence of thoracic radiculopathy. Here there is radiating pain which causes severe abdominal or chest pain and necessitates with focal weakness resulting in protrusion of the abdominal wall like a pseudo hernia. One must also take into cognizance the intervertebral space nerve root relationship while localizing these root syndromes in the setting of a lumbosacral disc disease. Almost all the lumbar disc herniations occur between the L4-L5 and the L5-S1 disc space. Not only the inter-disc space level, but also the location, the direction of the protruded disc is important because this determines which roots are predominantly affected. For example, if a L4-L5 root protrusion occurs posterolaterally, then it affects the L5 root that is destined to leave via the L5-S1 foramen. If it is a very laterally placed protrusion, then it may affect the L4 root, and a very medially placed region may affect the S1 root along its downward course. Central disc herniations are less common, but they affect the roots on both sides and they resemble a cauda equina syndrome. Now, in the setting of radiculopathies, the work of carrying out an electrophysiological evaluation is extremely variable. Most of the patients have only radicular pain and sensory symptoms which do not have any measurable or quantifiable electrophysiological correlates with the standard nerve conduction studies or the needle EMG studies. Anyway, at least one motor and one sensory nerve in the affected limb has to be studied, and there are several screening EMG protocols that involve 5, 6 or 7 muscles that have been described to confirm radiculopathy as well as to exclude polyneuropathy and other peripheral nervous system localizations. Whatever be their value, they help to exclude entrapment neuropathies and generalized polyneuropathies. Now, in the setting of monoradiculopathies, imaging, particularly MRI, is the key investigation in confirming the diagnosis. It probably is more important than the electrophysiology. Therapeutic decisions can be taken without the confirmatory findings provided by an ENMG examination, and treatments such as surgical or medical treatment can be decided based on the diagnosis that is uncovered by these imaging studies. With this, we move on to the plexopathies. The diagnosis of plexopathies as well as the localization of a lesion within the plexus is generally more difficult because of the complex anatomy. So, one must have a strong knowledge of the anatomy as well as the sensory and motor supply of the individual components of the plexuses. So now, let us briefly revise the anatomical intricacies of each of these plexuses and discuss the clinical features with respect to their dysfunction, particularly those with a regional predilection. First, the cervical plexus. The cervical plexus, as you all know, is formed by the anterior primary rami of the C1 to C4 spinal nerves. It is located behind the sternocleidomastoid and in front of the scalenus medius and the levator scapulae muscles. The cervical plexus consists of a series of anastomotic loops that lie in close association with the 11th and the 12th cranial nerves. And the branches of the cervical plexus can be divided into those that are predominantly sensory and those that are predominantly motor. Coming to the motor branches, the fibers from C1, C2 and C3 form this ansa cervicalis, and the nerve fibers from the ansa supply the infrahyoid muscles. These muscles aid in head flexion. Then the fibers from C3 and C4 give off branches to the levator scapulae muscles and the scalenus medius muscles, and these muscles aid in rotation of the scapula and lateral flexion of the neck. The phrenic nerve arises from the C3 to C5 roots and innervates the diaphragm. And in addition, the cervical plexus also gives off a minor supply to the sternomastoid and the trapezius via the spinal accessory nerve. Here are the sensory branches of the cervical plexus. They include the greater occipital nerve, the lesser occipital nerve, the greater auricular nerve, the transverse cervical nerves as well as the supraclavicular nerves. And this is a diagrammatic representation of the cutaneous innervation of these nerves. Note that there is no dorsal root from C1 and it does not have any cutaneous sensory supply. Injuries to the cervical plexus are rather infrequent. Trauma and mass lesions constitute most of the etiologies in majority of the cases. The trauma may be in the form of penetrating wounds or iatrogenic injuries that are sustained during surgical procedures such as a carotid endarterectomy. The individual branches of the cervical plexus may also be damaged in specific situations. For instance, the great auricular nerve may be damaged during surgical procedures to the face or neck, such as facelift or parotid surgery. The lesser occipital nerve may be injured during surgical procedures involving the posterior cervical triangle, such as a radical neck dissection. The phrenic nerve, on the other hand, is more likely to be injured by a lesion in the mediastinum rather than by damage to the cervical plexus itself. A patient with cervical plexopathy may experience altered sensation in the form of sensory loss or paresthesias or pain in the distribution of the affected branches. For instance, a lesion in the greater auricular nerve may cause loss of sensation over the mandible or the lower pinna. When the muscular branches are involved, there is weakness of the anterior and lateral head flexion because of involvement of the infrahyoid and the scalene muscles. In addition, there may be weakness of scapular rotation because of the involvement of the levator scapulae muscle. There may also be some degree of weakness of shoulder elevation and head rotation because of the involvement of the trapezius and the sternomastoid muscles. The muscles affected and the degree of paresis depends upon the specific portion of the cervical plexus that is affected. Since the cervical plexopathies are not very common, we will not spend much time on them. We'll now move on to the brachial plexus. The brachial plexus supplies much of the upper extremity and the shoulder, and it is the most complex structure within the peripheral nervous system. It is a triangular structure that emerges from the spinal cord in between the scalenus medius and the scalenus anterior muscle and extends till the axilla. It's about 15 centimeters long, and it is formed by the anterior primary rami of C5 to C1 spinal nerves. The relative contribution of each of the roots to the plexus varies. The percentage of the sensory and motor fibers within each root also varies. The largest percentage of motor fibers is found in the C5 and C6 roots, while the largest percentage of sensory fibers is found in the C7 roots. The brachial plexus is divided into several components. There are 5 roots, that is classically from C5 to T1. There are 3 trunks, the upper, middle and lower. There are 6 divisions, 3 each of anterior and posterior. There are 3 cords, that is lateral, posterior and medial. And there are several terminal nerves. The brachial plexus also carries the sympathetic fibers. As mentioned earlier, there are 5 roots. Some nerves arise directly from the roots. They include the dorsal scapular nerve that arises from C5 and supplies the levator scapulae and the rhomboids, as well as the long thoracic nerve of Bell that arises from C5 to C7 and supplies the serratus anterior. The C5 ramus also contributes to the phrenic nerve as discussed earlier. And in addition, the C5 to C8 rami provide direct routes to the scalene and the longus colli muscles. The sympathetic ganglia sends postganglionic fibers through the T1 spinal nerves. The roots form the trunks. The trunks are located in the posterior cervical triangle behind the clavicle and the sternocleidomastoid. There are 3 trunks, that is the upper, middle and lower. Typically, the C5 and C6 unite to form the upper trunk. The C7 anterior ramus continues as the middle trunk, while the C8 and T1 coalesce to form the lower trunk. There are 2 nerves that arise from the trunks, and both of them arise from the upper trunk. They are the suprascapular nerves and the nerve to subclavius. The lower trunk lies adjacent to the subclavian artery and the apex of the lung, and this anatomical relationship is important when we come to the etiologies. Each trunk is divided into an anterior and a posterior division, all of which are retroclavicular. The anterior division supplies the flexor muscles, that is the muscles that are located in the anterior compartment of the arm and forearm, while the posterior division supply the extensor muscles, that is the muscles that are located in the posterior compartments of the arms and forearms. In the upper trunk, the relative caliber of the anterior and posterior divisions is equal, while in the middle trunk, the posterior division is much larger than the anterior division. Remember here that the middle trunk is nothing but a continuation of the C7 root, and therefore the C7 predominantly supplies the extensor muscles of the upper limbs. On the other hand, in the lower trunk, the anterior division is much larger than the posterior division. There are no nerves that arise from these divisions. And then we have the three cords, which are the medial, lateral, and the posterior cords. They are located in the proximal axilla around the axillary artery. The lateral cord is formed by the union of the anterior divisions of the upper and the middle trunks, and it comprises of the C6 and C7 sensory fibers and C5 to C7 motor fibers. Remember here that there are no C5 sensory fibers in the lateral cord, rather they are represented in the posterior cord. The lateral cord gives off the lateral pectoral nerve, the musculocutaneous nerve, and the lateral head of the median nerve. The posterior cord is formed by the union of the posterior divisions of all the three trunks. It contains the C5 to C7 sensory fibers and the C5 to C8 motor fibers. Remember that here there is no representation of C8 sensory fibers in the posterior cord. The posterior cord gives off the subscapular nerve, the thoracodorsal nerve, the axillary nerve, and the radial nerve. The medial cord is nothing but a direct continuation of the anterior division of the lower trunk. It consists of the sensory and motor fibers that are derived from the C8 and T1 roots, and it gives off the medial pectoral nerve, the medial brachial cutaneous nerve, the medial antebrachial cutaneous nerve, the ulnar nerve, and the medial head of the median nerve. Thus, the median nerve is the only nerve that is derived from the two cords, that is the lateral cord and the medial cord, while the rest of the nerves originate from a single cord. Here is the cutaneous innervation of the various nerves of the brachial plexus as compared to the dermatomal supply. And of course, all the muscles in the upper limbs are supplied by the various components of the brachial plexus. There are several anatomical variations within the brachial plexus. Classically, the brachial plexus is derived from the C5 to T1 roots. When the adjacent roots, namely the C4 and the T2 contribute, the brachial plexus is said to be expanded. As many as 7 roots may contribute to the formation of the brachial plexus. On the other hand, the brachial plexus may also be contracted with only 4 roots. Vertical shifts may occur in the cranial or caudal direction when the formation of the brachial plexus is shifted by one level upwards or downwards. When the C4 contribution is large and the T1 contribution is small, the brachial plexus is said to be prefixed. On the other hand, when the C5 contribution is small and the T2 contribution is large, the brachial plexus is said to be postfixed. Now note here that these one segment shifts do not really affect the plexus arrangement by themselves, and thus they do not affect the lesion localization either by clinical or by electrophysiological evaluation. Coming to the pathologies of the brachial plexus. Brachial plexopathies can be classified in several ways, but they are best classified based upon the anatomical regions that are affected as supraclavicular, retroclavicular, and infraclavicular plexopathies. Although this approach sounds very simple, it has a lot of clinical utility because the incidence, the severity, the prognosis, the etiologies, and the lesion types vary among these regions. The supraclavicular plexus, by the way, is further subdivided into the upper plexus, the middle, and the lower plexus, and this again is a very clinically relevant classification. But note here that the infraclavicular plexus is not further subdivided because in this region the lesions do not show any specific predilection with respect to either the incidence, the severity, the prognosis, or the nature of the lesion. So, the anatomical classification of brachial plexopathies has clinical relevance. Some disorders are site-specific and they affect specific portions of the brachial plexus. For instance, in supraclavicular plexopathies, the classical examples of upper plexus syndromes are the Burner syndrome, rucksack paralysis, and the classical postoperative paralysis. And the classical examples of the lower plexus syndromes are the true neurogenic thoracic outlet syndrome, post-median sternotomy syndrome, and the Pancoast syndrome. Coming to the lesions that affect the infraclavicular plexus, radiation plexopathy classically affects the lateral cord, while the midshaft clavicular fracture classically affects the medial cord. Fracture of the proximal portion of the humerus has a tendency to injure the axillary nerve, while surgical correction of shoulder dislocation has a propensity to affect the musculocutaneous nerve, and compartment syndrome predominantly affects the median nerve followed by the ulnar nerve. And then, And then there are these conditions that do not have any specific predilection for affecting any specific site within the brachial plexus. For instance, the classical example being neuralgic amyotrophy. Most of the brachial plexopathies are axonopathies, therefore they clinically manifest with weakness and sensory loss. In supraclavicular plexopathies, the pattern of there is segmental pattern of impairment, that is the sensory loss occurs in a dermatomal pattern and the weakness follows a myotomal pattern. On the other hand, in case of infraclavicular plexopathies, the impairment is non-segmental. Rather, it follows the pattern that is observed with the involvement of the multiple terminal nerves. So, in the case of upper plexus involvement, the weakness is seen in the muscles that are innervated by the C5 and C6 levels, that is the spinatite that aid in external rotation of the arm, the deltoid that aids in abduction of the arm, and the biceps and the brachioradialis that aid in elbow flexion. Some of the muscles that are partially innervated by the upper plexus, such as the flexor carpi radialis and the pronator teres, may also be partially weak. Very proximal lesions involving the roots cause weakness of the phrenic nerve, the dorsoscapular nerve, and the long thoracic nerve. The middle plexus comprises the C7 root and the middle trunk, which is nothing but a continuation of the C7 root, and therefore the clinical features resemble a C7 radiculopathy. Now, isolated lesions of the middle plexus are rather rare, but when they occur, they cause weakness of the elbow and wrist extension. They cause weakness of the elbow, wrist, and finger extension. In case of upper plexus involvement, the biceps and the brachioradialis reflex is diminished or absent, while in the case of middle plexus involvement, it is the triceps reflex that is diminished or absent. The lower trunk has the elements from C8 and P1 roots, and therefore lesions of the lower trunk involve all the intrinsic hand muscles that are innervated by the median nerve and the ulnar nerve. There is no reflex abnormality in case of lower plexus involvement. Coming to the patterns of sensory impairment, in case of upper plexus injuries, the sensory loss is expected to be present over the lateral portion of the arm and forearm and the hand. Lesions of the middle plexus would cause involvement of the middle finger that may extend to the posterior aspect of the forearm. While in case of lower plexus involvement, the sensory impairment involves the medial portion of the forearm and the medial hand and may also extend to involve the medial arm. As mentioned earlier, infraclavicular plexopathies produce deficits resembling involvement of multiple terminal nerves. Therefore, the lateral cord involvement is recognized by a combination of weakness in the musculocutaneous and the median nerve territory. That is, they manifest as weakness of elbow flexion, wrist flexion, and finger flexion, except the intrinsic hand muscles that are supplied by the median nerve. On the other hand, the involvement of medial cord results in weakness of the ulnar nerve and the median nerve innervated intrinsic hand muscles. While lesions of the posterior cord result in weakness of the radial nerve innervated muscles along with those that are innervated by the axillary nerve, the thoracodorsal, and the subscapular nerves. So the shoulder abduction and rotation, the extension of the elbow, wrist, and fingers are weak. In addition, there is also sensory loss in the regions corresponding to the areas innervated by these nerves. As always, history plays a cornerstone as far as deciphering the etiology is concerned. The initial symptom and the subsequent symptoms are important. In the case of Burner syndrome, which is common in contact sports, there is a sudden and forceful separation of the head from the shoulder, and this leads to a traction on the upper plexus. So, the subject experiences an abrupt onset of pain and paresthesias, which is sharp and burning in quality, and it extends from the shoulder distally, often up to the thumb. These symptoms often subside within a few minutes. On the other hand, in the case of a neuralgic amyotrophy, there is often an antecedent event, which is followed by severe pain and weakness that evolves over a few days, typically over about 7 to 10 days. Apart from this, the circumstances and setting that surround the onset, as well as the past medical history, have to be reviewed. The temporal association of the symptoms with, let us say, backpack use, trauma, or surgery provide an obvious etiology. In the setting of trauma, the position of arm at the time of impact suggests which fibers are most likely to be affected. Apart from these, the presence of concomitant injuries also give an indication as to which portion of the plexus is likely to be injured. In the brachial plexus, the lower two roots commonly avulse, while the upper two roots most commonly rupture extraforaminally. This reflects the anatomical differences in their proximal anchorage sites, the angles of exit from the intervertebral foramina, as well as the individual root lengths. In the case of traumatic plexopathies, either accidental or iatrogenic following some surgical procedures, the injuries may affect the plexus directly, in which case the deficits occur immediately and are temporarily related to the event, or they may affect the plexus indirectly by forming pseudoaneurysms or hematomas, in which case the deficits do not occur acutely, and they may be noticed after a variable period following a trauma or injury. Primary or secondary neoplasms, except for the benign neoplasms, present with pain followed by deficits appropriate to the site of involvement. When the axillary lymph nodes are affected, they infiltrate the medial cord, as compared to Pancoast tumors, which cause a lower plexopathy. Autonomic involvement may also be present, resulting in a hot and dry limb and Horner syndrome. In contrast, the radiation-induced plexopathies are painless and they present with paresthesias in the distribution of the lateral cord, followed by weakness. Several of the brachial plexopathies characteristically manifest with pain, and that too early in the course of the illness. In case of Burner syndrome, there is an abrupt onset of pain in association with a contact sports injury that recovers rapidly. A sportsman may sustain several such burners during the course of a match, but they are all transient and permanent neurological dysfunction is rare. On the other hand, in the case of a neuralgic amyotrophy, there is nocturnal onset of abrupt and excruciating pain in the shoulder or the upper limb, that is in the periscapular region. This pain worsens by shoulder movement rather than by neck movement, and it subsides after 7 to 10 days, by which time the weakness becomes apparent. In the case of rucksack paralysis and classical postoperative paralysis, the patients present with painless weakness. Benign tumors and radiation plexopathies also manifest with paresthesias rather than with pain. One may be able to identify a supraclavicular tinel sign or a mass lesion when it is present. We have already reviewed the patterns of weakness based on the site of the brachial plexus involvement. In addition, specifically in the case of neuralgic amyotrophy, the proximally located motor nerves are predominantly affected, such as the long thoracic nerve, the suprascapular nerve, and the axillary nerves. But other nerves can also be affected, such as the anterior interosseous nerve, the musculocutaneous nerve, and even the phrenic nerve and the spinal accessory nerves that lie outside of the brachial plexus. In the case of neurogenic thoracic outlet syndrome, clinically, the patients present with greater involvement of the regions that are innervated by T1 rather than by C8. So, there is prominent thenar wasting, while pain and paresthesias are noted along the medial aspect of the arm, forearm, and hand. There is a lot to be said about the electrophysiological evaluation of the brachial plexus. Brachial plexopathies, being axonopathies in majority of the cases, produce reduction in amplitude of the sensory and motor action potentials. Anyway, to cut the long story short, these are basically the 5 sensory nerves that can typically be examined as a screening test, and based on the abnormalities found on these sensory nerve conductions, together with the clinical data, a more detailed protocol can be planned and executed in order to localize a lesion. While electrophysiology provides information about the functional connectivity of various components of the brachial plexus, imaging provides information regarding the anatomical or the morphological changes. There are several radiological tools that help to image the plexus, and the choice of imaging depends upon the clinical circumstances. One may just order a simple plain X-ray that may reveal a foreign body or fracture or diaphragmatic palsy. High-resolution ultrasound, CT scan, and MRI are widely available, and they can be used judiciously to identify a variety of etiologies such as these, as well as to precisely localize the injury, identify multiple sites of injuries, the presence of neoplasms, inflammation, and secondary effects such as denervation of the muscle, etc. These help in planning the further treatment. With these few words on the brachial plexus, we now move on to the lumbosacral plexus. The lumbosacral plexus is less complex than the brachial plexus since it does not have the interlacing trunks, divisions, and cords as in the brachial plexus. The lumbosacral plexus is derived from the T12 to S4 spinal roots. It is located within the substance of the psoas muscle. The lumbosacral plexus can be considered as comprising of two adjacent plexuses, that is the lumbar plexus and the sacral plexus. The lumbar plexus being formed by T12 to L4 roots and the sacral plexus being formed by L4 to S4 roots. Even though there is less merging of the nerve fascicles, the lumbosacral plexus is complex enough, and in that there are many nerves that branch directly from the plexus. The lumbar plexus gives off the following nerves: the iliohypogastric nerve, the ilioinguinal nerve, the genitofemoral nerve, and the lateral femoral cutaneous nerve. There are the two large branches, that is the obturator nerve and the femoral nerve, and the L4 also contributes to the lumbosacral trunk that joins the lower roots to form the sacral part of the lumbosacral plexus. The iliohypogastric, the ilioinguinal, and the genitofemoral nerves are predominantly sensory nerves, while the lateral femoral cutaneous nerve is a pure sensory nerve. The larger branches, that is the obturator nerve and the femoral nerves, contain both sensory and motor fibers, and these are the mixed nerves. Apart from these, there are several small branches that arise proximally from the anterior primary rami from each segment, and they directly innervate the psoas muscle and the quadratus lumborum muscles. Thus, the nerves of the lumbar plexus innervate the skin over the lower portion of the anterior abdomen, the anterior, lateral, and medial portions of the thigh, and the medial portion of the leg. Coming to the muscles that are innervated by the lumbar plexus, the hip flexors, the hip adductors, and the quadriceps, as represented by the shaded portions in this figure, are innervated by the lumbar plexus. The sacral plexus gives off the following nerves. The posterior primary division gives off the superior and inferior gluteal nerves as well as the common peroneal nerve, while the anterior primary divisions gives off the tibial nerve, the posterior femoral cutaneous nerve, as well as the pudendal nerve. The common peroneal nerve and the tibial nerve travel together as the sciatic nerve. The nerves arising from the sacral plexus and their branches supply the skin over the posterior portion of the thigh, the posterior leg, the lateral leg, as well as the entire foot. The muscles that are innervated by the sacral plexus include the hip abductors and extensors, the hamstrings, the foot muscles, as well as the sphincters, as represented by the shaded areas in this figure. Coming to the etiologies, the most important cause of lumbosacral plexopathies are trauma and neoplasms, apart from diabetes and non-diabetic lumbosacral plexopathies that are immune-mediated. The plexus is fairly well shielded from direct trauma by virtue of its deep location. The lumbosacral plexus is therefore less prone to stretch or traction injuries as compared to the brachial plexus. So the injuries have to be really severe or penetrating in order to damage the lumbosacral plexus. But the plexus is vulnerable to be involved in disorders that affect the adjacent vascular and other visceral structures. And one important cause is neoplastic infiltration, which is one of the relatively more common etiologies. Apart from these, retroperitoneal hematoma can also be seen as a complication of various coagulopathies such as hemophilias and use of anticoagulants. Rarely, hemorrhage can occur into the iliopsoas muscle and create a compartmental syndrome and thereby damage the lumbosacral plexus. Psoas abscess from tubercular or pyogenic osteomyelitis is another important cause. And during labor, the descending fetal head may compress upon the lumbosacral trunk as it passes over the pelvic brim. As in the case of the brachial plexus, a lumbosacral plexopathy is easily recognized by the presence of pain and sensory motor deficits in the distribution of multiple spinal roots and peripheral nerves in the lower limbs. And based upon the distribution of these sensory motor deficits, one can decide as to whether the entire plexus is affected or only a portion of it is affected. Lesions of the entire plexus are rare and they usually incomplete. They cause weakness of the entire lower limb along with sensory loss and hyporeflexia or areflexia. On the other hand, lesions of the lumbar plexus cause pain and sensory loss in the anterolateral and medial thigh, while weakness involves the quadriceps, the hip flexors, and the hip adductors. In the case of sacral plexopathies, the sensory loss and weakness involves the posterior thigh, the leg, and the foot. As always, history plays an important role in the clinical evaluation, particularly the timing of onset of symptoms as well as their progression. The onset and the progression are obviously acute and rapid in the case of trauma or iatrogenic injuries following procedures such as femoral catheterization. The course is more gradual in the setting of an abscess or an aneurysm. Exercise-induced ischemia of the lumbosacral plexus may occur in patients with high-grade stenosis or occlusion of the arterial supply of the lumbosacral plexus. In the case of diabetes, the patients experience pain followed by weakness and atrophy. The same sequence of pain which is present in the back, the pelvic region, or radicular leg pain followed by sensory impairment and weakness can also be seen in the setting of cancer. But here, the course is more protracted over weeks and months as compared to diabetic plexopathy that evolves over a few days to weeks. The clinical setting in which the deficits occur give a straightforward clue for their etiology. In case of traumatic injuries, gunshot wounds predominantly affect the upper plexus, while the lower plexus is more commonly involved in case of motor vehicular accidents. Most of the etiologies of lumbosacral plexopathies cause painful plexopathies. In the case of diabetes, the pain is sharp or burning in quality, while in the case of neoplasms, the pain is dull, achy, and poorly localized. Sometimes it may even be radicular and mimic a radiculopathy. If the iliopsoas is infiltrated, the patient may report difficulty in lying down supine with the affected leg extended. In the setting of coagulopathies, such as hemophilias or a patient on anticoagulant therapy, a retroperitoneal hematoma should be suspected in any patient who develops a back pain or a thigh pain or a groin pain, and this pain particularly worsens on leg extension. In fact, the patients may prefer to keep the legs flexed and externally rotated in order to minimize the pain. An acute painless ischemic lumbosacral plexopathy, often without signs of limb ischemia, may be seen in this case of aortic dissection. Radiation plexopathy causes pain in only about 50% of the cases, and even when pain is present, it is not the presenting feature and it is not usually very severe as compared to the neoplasm associated pain. Among the systemic symptoms, weight loss is a prominent symptom that is seen in both diabetic and non-diabetic plexopathies, apart from patients with systemic malignancy. General physical examination also gives clues to the underlying etiology. In most of the patients with neoplastic plexopathies, the patients already have an established diagnosis of a malignancy, and plexopathy occurs in the setting of an already established malignancy. However, in about 15% of the patients, plexopathy may be the initial manifestation, and in this setting, palpation of the abdomen and the groin region may reveal a mass which gives a clue for an underlying malignancy. The presence of a pulsatile mass may indicate an underlying aneurysm. A hot and dry foot may sometimes be seen because of involvement of the sympathetic trunk as the presenting manifestation of cancer. Myokymia is a characteristic feature of radiation plexopathy, but this is not a very sensitive sign because it is seen in only about 60% of the patients, and its absence does not really exclude a radiation plexopathy. Coming to the patterns of weakness, diabetic and non-diabetic lumbosacral plexopathies are focal and patchy that involve both proximal as well as the distal musculature, and then they may eventually progress to involve the contralateral side as well. In the case of neoplasms affecting the lumbosacral plexuses, the lower plexus is most commonly affected in about 51% of the cases, while panplexus involvement is the least common, seen in less than 20% of the cases. Again, as in the case of brachial plexopathies, the electrophysiological diagnosis of lumbosacral plexopathies relies on the presence of abnormalities in the distribution of two different peripheral nerves in at least two different root distributions. And again, as in the case of brachial plexopathies, most of them are axonopathies, and therefore they are reflected as reduction in the amplitudes of the sensory and motor action potentials. These are the sensory and the motor nerves that are commonly examined by nerve conduction studies. And among these, the saphenous nerve and the lateral femoral cutaneous nerve that examine the upper plexus are technically slightly difficult to perform. The needle EMG should be planned in such a way so that it covers the muscles that are innervated by all the roots that form the lumbosacral plexus, so as to assess the exact extent of the abnormalities. MRI is the imaging modality of choice while studying the lumbosacral plexus. It may show abnormal signal intensity, enhancement, enlargement, edema, and it may help to identify which segment is precisely involved in the lumbosacral plexus. It reveals a wide variety of etiologies that help in planning the further treatment. With this, the topic of localization of radiculopathies and plexopathies is rather vast and daunting. And at the end of this, many of you must still be having the burning question as to how to differentiate the radiculopathies from other differential diagnoses that affect the peripheral nervous system, particularly how to differentiate a monoradiculopathy from a mononeuropathy. Here are the common case scenarios. For instance, in case of a patient who presents with weakness of the wrist and finger extensors, there can be multiple localizations, including the C7 root and the radial nerve. So one needs to apply the knowledge and understanding of the anatomy with the clinical features so as to distinguish these two very common peripheral neurological localizations. The motor examination should focus on identifying the pattern of weakness. Atrophy and fasciculations may also be present, and they follow the same patterns as the weak muscles. Here, in this setting, the wrist flexors and pronators are innervated by C7 root, but not by the radial nerve. And again, the brachioradialis is a radial innervated muscle, and it is not supplied by the C7. So testing these two muscles can help to distinguish a radial neuropathy from a C7 radiculopathy. While examining the muscle stretch reflexes, the triceps reflex can be impaired in both C7 radiculopathy as well as a proximal radial neuropathy. In contrast, an impaired brachioradialis reflex occurs only in the setting of a radial neuropathy, so it supports a radial neuropathy over a C7 radiculopathy. Again, the sensory examination identifies the pattern of sensory loss or impairment that are unique to each nerve or root in question, and this helps in the diagnosis. So in this setting, it includes examining the thumb and the third digit, which helps to distinguish the C7 radiculopathy from a radial neuropathy. Apart from finding out whether the pattern of sensory deficits fit in a dermatome or a nerve distribution, while acknowledging that there are many common areas of sensory disturbance between mononeuropathies and monoradiculopathies, one must also note the ratio of loss of pain versus the loss of touch sensation. In the case of peripheral nerve involvement, the area of reduction in touch is less than the area of reduction in pain. The reverse is true in case of a radical involvement. The boundaries of impaired sensation are rather indistinct in case of root lesions, while they are slightly more sharply defined in the case of a peripheral nerve involvement. And of course, one can elicit the irritative signs, which are used to identify monoradiculopathies, by which aggravate or reduce the symptoms, such as the Sperling's maneuver, etc. Likewise, there are also the irritative signs that can be used to identify the mononeuropathies, wherein any nerve with a segment that runs superficially in a vulnerable position can be tested as a part of the Tinel sign in the case of a median nerve over the wrist, the ulnar nerve at the level of the Guyon's canal, or the radial nerve at the level of the spiral groove. In general, the weakness and atrophy are less common or less prominent in case of monoradiculopathies because of the overlapping supply of the roots. Most of the muscles, as we've already discussed, have got a polyradicular supply. It is also important to identify injuries to the roots and distinguish them from the more peripherally located plexus lesions because the prognosis associated with the root injuries are rather grave. The ones that have the highest discriminative value are the presence of severe pain in an anesthetic limb as well as Horner syndrome. Other features such as long track signs that indicate severe trauma and concomitant injury to the spinal cord and a presence of a transverse process fracture also favor the presence of a root avulsion. Now, in the context of radiculopathies, one must remember that while radiating pain is a characteristic feature of root involvement, pain due to entrapment neuropathies may also radiate proximally and therefore mimic a radicular pain. In this case, signs of local or focal irritation such as the Tinel sign and the Fallon sign may be useful in distinguishing a radiculopathy from a more peripheral entrapment neuropathy. Joint pain and musculoskeletal pain may also mimic a root pain. There are a number of orthopedic conditions that can be mistaken for radiculopathy or plexopathy, and unless these are carefully examined, including the joint mobility, this may lead to unnecessary investigations and sometimes unnecessary treatment. At this point, I would also like to introduce the concept of referred pain, wherein the acute visceral disease may cause pain in the segmental distribution and closely mimic a radicular pain. This referred pain needs to be distinguished from radicular pain. While radicular pain starts in one place and travels along the path of a nerve root, in the case of referred pain, there is a zone of pain-free region between the actual site of origin and the actual site of pain. That is, pain is distant from the source of the viscera, which is the source of pain. For example, the cardiac pain is felt over the left arm. Again, there is a lot to be said about the electrophysiological protocols and parameters that help to distinguish radiculopathies from plexopathies and other neuropathies such as mononeuropathies and mononeuritis multiplex, etc. But at this point, I would like to just highlight the fact that the dorsal root ganglion, the location of the dorsal root ganglion plays an important role in interpreting the nerve conduction studies. So in the case of nerve lesions, because in the case of nerve lesions or the plexus lesions, because they're postganglionic, the sensory nerve conduction studies are likely to be abnormal. While in the case of root lesions, because they are preganglionic, the sensory nerve conductions are normal. In addition, plexus evaluation requires an extensive ENMG study. Side-to-side comparison is useful. Sensory conduction studies are generally more useful in identifying various patterns of abnormalities and thereby the localization as compared to the motor conduction studies, but exceptions are always there, as in the case of neuralgic amyotrophy, where the sensory nerve conduction studies are largely preserved. With this, I would like to conclude by mentioning that integrating the requisite anatomical, pathophysiological, and neuromuscular knowledge with the detailed clinical assessment and other ancillary tests, one can localize and characterize a lesion with fair degree of certainty. This ability requires an understanding of the relevant anatomy as well as familiarity with the various disorders that affect the radicals and the plexuses. The clinical diagnosis and possible etiologies can be supported and confirmed by appropriately performed ENMG and imaging studies. Thank you, and if there are any questions, I'll be happy to answer them.
Thank you, Dr. Madhu. At present, there are no questions at present. Is Dr. Madhu there? Dr. Madhu, can you keep your video on? Yeah. So let me ask you very seriously. It's having an echo, right? Is it okay now? Can you hear me? Okay, can you hear me now? Yeah, okay. Madhu, how long do you take to do a brachial plexus EMG for one patient, in your experience? If you want to fully evaluate the patient? How long do you take?
Quite time consuming. It takes a lot of effort. The patient also has to be patient. We also have to be patient. And there are also technical problems because of the system related issues. Sometimes grounding, artifacts come. So practically speaking, it is quite difficult to perform. We also have to go well prepared because based on the clinical picture, we have to decide which ones otherwise it is not practically possible to do everything in a single patient. We have to decide based on a priori hypothesis which portion we want to specifically assess. And then, of course, the imaging is there, which is complementary. And that also adds on to the information.
I think that learning point resident
Can I add a point here?
Yes, sir.
The best thing is to do detailed clinical examination, generate a hypothesis, and go about it.
Yeah, usually some places when you usually lab may they directly go and try and do the Plexus protocol directly and do and after some time you are totally confused what to do next. Okay? Because if you are not examining the patient and you don't have an a priori hypothesis what you're going to do, then once you start your Plexus protocol, you end up with okay, some things sometimes you grossly can make out, but otherwise to pinpoint it's very difficult unless you have examined the patient properly and made a
I will suggest do sensory nerves, all median and all radial. That excludes, if they are present, that excludes avulsion.
So there are some few questions now that's asked. How brachial plexus study is helpful in prognosticating surgical outcomes in traumatic plexus injury?
It depends upon the timing of the study because the findings evolve with time. Immediately, if we perform, we may not have many findings. Generally, the sensory potentials help in localizing, while the motor study helps in prognosticating. And this motor study, the findings would depend upon the timing because we have to give time for that Wallerian degeneration to happen. So, initially, we may find only reduced recruitment, and then with time, we find the spontaneous activity occurring and then the neurogenic changes happening. If there are only sensory changes without much motor changes, then the prognosis may be better. If the proximal components are involved, then of course the prognosis is bad.
Usually the question may be related to the plastic surgeons they are sending, So plastic surgeon will send you. Yeah, Shruti wants to come in, yeah.
Here actually in traumatic plexopathy, there is very little role for diagnosis itself. So we don't need to do a EMG to diagnose disease. As Dr. Madhu was telling, it's important to see if there is a possibility of avulsion. Because if the sensory potentials are normal with very severe weakness and sensory loss, that indicates a poor prognosis. So most important, I think, role for plastic surgeons here, what they want from us, is one to see if there is reinnervation starting or not, which means that is a nerve in continuity or not. So by 6 weeks, if there is no evidence of reinnervation, it's a good evidence that patient may need a surgical procedure to reattach the nerves. Second, you want to know if they usually transfer one nerve from one muscle to the other. So they want to know if that muscle is affected or not. For example, if they want to transfer from FCR to FCU, they want to know if FCR is okay. So these are probably two main reasons why plastic surgeons need us. So if we give a report saying that lower brachial plexopathy, I have understood that it is pretty much not useful for them. My husband is a plastic surgeon, that's why.
But I think the best Dr. Professor B. Indira is interested in repair brachial plexus. They must be having some protocols in immense. Can you highlight about it, Madhu?
So we have to do the standard nerve conduction, that is the median, ulnar and the radial. And then we extend it to do the medial and the lateral antebrachial cutaneous nerves, that is for the sensory. And then we have to do the proximal conductions, that is for the musculocutaneous nerve and the axillary nerve. And then depending upon the findings, then we proceed further, sir. Side-to-side conduction has to be done, particularly if it is unilateral, because side-to-side comparison is important, particularly for the uncommonly performed nerves, so that we see the difference in the amplitude of the potentials to make out the reduction.
So when is the ideal time to, after injury, when is the ideal time? Is it 3 months, 6 months to get a good picture about the damage? When do you want it?
Probably after 3 to 6 weeks, sir.
3 to 6 weeks.
Okay, so next is how to differentiate CAT1 root lesion from ulnar neuropathy. I think that you have answered during your lecture, so that we will skip it. How common is idiopathic lumbar plexopathy?
It is quite uncommon. I'm not sure of the frequency, but it's a rather uncommon condition.
Okay, I think the rest of the questions you can type on the answer. You can type on the chat box. I mean, question answer session. Dr. Madhu can type. I think we'll switch to the next lecture.